Hello, everybody. Welcome to a knee guru session combined with joint operations as a new format. And the topic today is managing arthritic pain and knee injury. Now, I'd be really glad if you all just put something in the chat so that we know you're there and you're watching and that you can hear. Good. Okay, that's excellent. All is fine. Very nice. Thank you. This is a private chat, so you can't actually chat with one another, but you can ask questions and we will flag the questions to ask the surgeon afterwards. So this collaboration is something new, and it's a collaboration with knee guru and joint operations, and they've got an educational platform called JOEL, which stands for Joint Operations e-learning. And our speaker is Mr. Raghbir Khakha, who we will introduce in a short moment. And what we're going to do today is, the topic is actually quite long, so we're going to split it into two parts. He will talk initially about the management of arthritis, and then we'll have questions and answers and see how we go. And then the second part is about knee injury, and there'll be some special emphasis on the current COVID situation. So I'd like to introduce, first of all, Richard Foster, who is the Managing Director of Joint Operations, and he will, in due course, introduce our speaker. So I'm going to leave the screen. Just remember to put your questions in the chat. Thank you.
Thank you, Sheila.
Richard.
And thank you, Sheila, and welcome to everybody from the Knee Guru subscribers and viewers. Thank you very much for giving up a portion of your Friday evening to listen to what I think will be a really interesting webinar and question and answer session. So in terms of the topic of conversation, I work in orthopedics, and the level of progress that's been made over the last, well, decades, really 3 decades, in terms of the design of arthroplasty joint replacements has been tremendous. Knee replacements, hip replacements, even ankle replacements and wrist replacements. And if you receive a knee replacement, you can now confidently expect that will serve you well for a decade or a decade and a half. But it is very much a one-way journey. As part of receiving a knee replacement, having that implanted, the surgeon needs to cut away all of the parts of the knee that move together. And so there's no ability to kind of step back up the hill once that's happened. And there's a growing cohort of surgeons around the world whose focus really is to try and preserve the joint rather than replace the joint and delay that knee replacement as long as possible, on the basis that the best knee anybody's ever going to have is the one that they're born with. And so let's try and keep it as long as we can. And this speciality has really evolved in the last 10 years, which in medicine and surgery is a very quick period of time. And we've now got a range of technologies that people can choose from, some of which are still very much experimental, but maybe promising or perhaps unproven, and some of which have become the standard of care and are broadly accepted. And so what we really need is a guide to talk us through that. And Mr. Khakha is I've had the pleasure of knowing Mr. Khakha for 5 years, and he's an exceptional surgeon in terms of his technique and knowledge of the anatomy, but I think also he's a very good doctor. He has a lot of empathy, and I've not been one of his patients, but I'm sure that if you are a patient, then you will have someone who takes the opportunity to understand what it is that you're looking for. He's a specialist in joint preservation. He's had fellowships in the United States and in India and in the UK with some of the best trainers, and currently holds a consultant post in Guy's with a strong emphasis on managing the early arthritic knee. So let me hand over to Mr. Khakha, and Rags, you can go and start your talk.
Brilliant. Richard, that's a very kind introduction. Many thanks. And it's a real honor to be presenting to everybody here today. So I'm just going to share my screen and we can get started on the presentation. Okay, so as Sheila and Richard kindly introduced, we're going to be talking today about managing arthritic pain and knee injury. My name is Raghbir Khakha, and I'm a consultant surgeon, and my interests are around osteoarthritis and sports injuries. So to start off with, we're going to talk about osteoarthritis, the scale of the problem, and how we are currently managing it from operative through to non-operative measures. We're going to look at the alternative options that are available in managing this quite debilitating disease. We're then going to change the topic and go into knee injuries and what the current guidelines are with regards to management of knee injuries and which cohort of patients require urgent attention. As Richard mentioned in the introduction, I'm a knee surgeon, work at Guy's and St Thomas's. I also work with orthopedic specialists. And really my interest is around all elements of knee injuries and knee osteoarthritis. With these two combined, I have a passion for preserving the joint where at all possible. So let's dive into the topic of osteoarthritis. We know that this is the greatest cause of disability within the United Kingdom. The proportions are similar around the world, no matter which country that you come from. In the UK, it affects over 17 million people. That's a huge burden on the population, with over 30 million working days lost every year. With regards to the spend on the public health service, the National Health Service, it totals up to 4.7 billion, with 20% of these patients having a greater employment rate compared to their healthy counterparts. And a quarter of patients suffering with osteoarthritis will go on to retire earlier. We know the proportion is the same across the United Kingdom, affecting all of the individual countries, anywhere between 26 to 29%. And we know that worldwide, this is a very similar percentage. We also know that it affects the female population greater than the male population. Traditionally, osteoarthritis has always been thought to be a disease of the elderly, and this graph does demonstrate that it affects predominantly those who are over the age of 75. However, if you look at the left of the graph, you can also see that the younger age group between 45 and 64 are also significantly affected. We also know that osteoarthritis is linked to the level of deprivation, as highlighted in this graph. Now, the end stage of osteoarthritis is performing a form of joint replacement. We know that if we look at the hip data, in the UK alone, 106,000 hip replacements were performed in the year 2018, with the majority affecting the female population, and the average age being in the late 60s to 70, with the predominant diagnosis being osteoarthritis. Now, 90% of patients will have osteoarthritis. The other 10 will either have rheumatoid arthritis, or the replacement may be due to fracture of the hip. And the average patient would be considered being overweight. Now, it's a very similar picture for knee replacement data. Nearly 110,000 joint replacements were performed in 2018. They're slightly down compared to 2017. Once again, the figures are similar in terms of the female preponderance to developing osteoarthritis. And in this case, 98% of patients would have had a diagnosis of osteoarthritis. In this group, on average, the patient would typically be obese. So what is the current situation? As Richard and Sheila alluded to, we're going to pay a little bit of focus to the current COVID-19 situation. We know that patients are having reduced access to healthcare professionals due to hospitals focusing on this current pandemic and managing the sick patients who've developed COVID-19. As a result of this, operating lists that would normally take place to perform joint replacement surgery have now stopped. And we anticipate that this will be the case for the next 3 months, if not longer. If you haven't seen an orthopedic surgeon already for your joint pain, it's likely to be that you'll wait longer to see them. And those of you who are awaiting joint replacement surgery will be waiting until theatre lists start to resume. And we know that with the current lockdown, most patients aren't able to get out and do their exercise, which is very important in maintaining good joint movement and a healthy joint. So what guidelines do we have to follow in this current situation? Well, the British Association for Surgery of the Knee looked at the following options, including the non-surgical management of knee arthritis, with a particular emphasis looking at intra-articular, that is to say, joint injections using steroid, and the use of non-steroidal anti-inflammatory drugs. So if we look at steroids specifically, we recognize that when we inject into the knee joint, there is a small amount of absorption into the bloodstream. We know that based on past experience with severe viral lung injury, that there is a risk of poorer outcomes. Therefore, the Royal College of Anaesthetics have recommended that steroid injections are used with caution, if at all. We've had some excellent guidance from the National Health Service Medical Director, who have suggested that if you are suffering with, if there is no increased risk of suffering COVID-19 if you start to take non-steroidal anti-inflammatory drugs. However, we know, and those of you who suffer with ailments such as asthma, that this can be a contraindication. That is, it is recommended not to take non-steroidal anti-inflammatory drugs, as this may exacerbate symptoms related to the lung. Therefore, the advice is that in those who are suffering with COVID-19, to avoid using non-steroidal anti-inflammatory drugs and use paracetamol instead. However, for those of you who are suffering with osteoarthritis, you should not stop taking them. Now, the Osteoarthritis Research Society International, otherwise known as ORSI, looked at evidence for lots of different non-operative therapies for osteoarthritis. They in fact looked at 60 different interventions, and they categorized them in accordance with the level of evidence that we have available. So if you look at the highest level of evidence, what is the most beneficial treatment of choice for managing arthritis without doing an operation? At the top of the list comes land-based exercise programs. That is to say, physiotherapy is very important in management of arthritis. Now, we know in the current climate it is proving very difficult to come across physiotherapists because of the current lockdown. But what you may not know is there are lots of physiotherapists who are currently doing virtual sessions. So if you have access to a laptop or an internet connection, you can get access to a physiotherapist and do some exercise. We also know using topical non-steroidal anti-inflammatory drugs, it is extremely effective in helping to reduce pain. These preparations are typically available from your local pharmacist. The next level down recommends the use of pool-based therapies. Some of you may have come across hydrotherapy, which is very good at helping building up the muscle bulk around the knee joint while reducing the pressure going through the joint. And this is very effective. We've also already touched upon the oral use of NSAIDs, providing, of course, there's no medical contraindication. We haven't touched upon the use of intra-articular hyaluronic acid, and certainly there's evidence to suggest that this is useful in managing pain symptoms in osteoarthritis. So what is hyaluronic acid? Well, hyaluronic acid aims to mimic similar substances that are found within the knee joint. It typically is described as a lubricant or a shock absorber, and it comes in different types, including a single shot, multiple shots, or those which are combined with steroid. The guidance by ORSI suggests that patients on average should expect pain relief at and beyond 12 weeks, and that it has a more favorable safety profile compared to the use of steroids. That is to say that we know that if you get steroid absorbed into the bloodstream, this can have a negative respiratory effect, but we do not expect the same with hyaluronic acid. And as I previously mentioned, you can get either a single preparation or a course of 3 to 4 injections, which are typically 1 to 2 weeks apart. Before we go into knee injuries, I think we'll take a small break there and take any questions.
Richard's come back on, and you've got 2 questions, Richard, which we see in the stream. So if you'd like to pose those and explain what you mean by joint preservation surgery.
Okay, so taking the liberty question for myself first, Rags. Well, actually 2 questions, taking an even bigger liberty. So how early do you need to, or ideally see a patient who's got early arthritis, so they're starting to get some changes in their joint? How early do you need to see them in order for joint preservation surgery to be possible, as in not going straight to an arthroplasty? And also, do you have any tips for patients who are talking with their GPs on how to get an appropriately timed referral to a specialist such as yourself?
Brilliant, thank you, Richard. Yeah, so those are really good questions. Regarding the early osteoarthritis patients, it's important to see a surgeon, or certainly a specialist who deals with joint preservation surgery sooner rather than later. The purpose of that is that we know that we can delay the onset, or certainly reduce the chances of going on to have a major arthroplasty surgery the sooner we see patients. So we can make an assessment based on clinical examination, using simple radiographic methods, and identifying which patients may or may not benefit from joint preservation surgery. Of course, out of the proportion of patients that we do see, very few of them require surgical intervention. The vast majority can do really well with the appropriate rehabilitation program, and as an intermediate may require simple injections which may not be detrimental to the knee joint. We're certainly coming away from just using straight steroid, because we know that it can have a negative impact onto the knee joints. So in summary, I would recommend get a referral sooner rather than later, and it may be that we can prevent any further longer term damage. Now, with regards to getting referrals or access to seeing an orthopedic surgeon, I think that's a very difficult one, and something I think most patients would sympathize with, and it's a great question. Now, we know that the GP practices and hospitals alike are busy with lots of different patients, but we know that osteoarthritis is hugely debilitating, and it really affects the way that people can enjoy their lives, spend time with their families, a working life. It affects all elements of people's livelihoods. So I think if the argument is made that actually, you speak to your GP and say, well, it's affecting various aspects of my life. So whether that's affecting your ability to work, ability to sleep, ability to do sport and keep fit, then we know that if you're not doing any of the above, that can have a detrimental effect and have secondary outcomes which may not be good for you. For example, if you're not exercising, we know that it can have adverse cardiovascular risk factors, increased weight. As we saw from those figures, by the time patients get to having joint replacements, they typically have put on weight because they've not had attention sooner.
Okay, thanks, Raz. So be upfront and don't hold back when you're talking to your GP about the impact this is having on your life. And
Absolutely.
on a similar question from MD Shaw,
yes,
the treadmill running, is that good for people who've got knee OA, knee arthritis? Or should you, in fact, can I link that in with the second question? Are there any exercises to be avoided, also from MD Shaw?
Brilliant. So yeah, that's extremely topical. We know that in the past the advice has been to avoid running and impact activity, but there's a rather large published research article that demonstrates that actually running doesn't necessarily have adverse effects in developing osteoarthritis. Now, my personal recommendation when I see patients is that actually it should be done in a very stepwise fashion. Now, going straight into running can be very difficult if it's not something you've been doing for a period of time and you're looking to lose weight and getting your joint active. So my step-by-step recommendation would be to firstly start off cycling. Now, cycling is great because we know that you're moving the joint in a very similar fashion to how you run. You get great function of the quadriceps, which is extremely important to trying to offload the pressure going through the knee joint. It then almost warms you up and prepares you and prehabilitates you into getting into running. So once you get good and strong at doing simple bike exercises, gradually building up the resistance, running is something that you can do. But the body's very good at telling us if something is not good, and if it hurts, then avoid it, or certainly reduce the amount that you're doing. But the data suggests that it shouldn't progress your osteoarthritis.
Okay, thank you. And again, touching on the point that you raised there, if a patient goes to see a knee specialist surgeon with early arthritis, what should they expect? Is there an algorithm or a roadmap that people will typically be placed into in terms of physiotherapy, conservative treatment, so kind of injection therapy, and then surgery? Or how long in a duration of time can that last before you go under the knife, so to speak?
So yeah, great question. I guess it depends on the time that we get to see the patient at what stage they are with their arthritis. If we start at the very early stage of osteoarthritis, the typical algorithm would be to look at lifestyle modification, see where we can improve the muscle bulk around the knee joint, improve the amount of movement that is within the joint. So typically that would start with physiotherapy and lifestyle modification. So that may include weight loss as something that's very important in trying to just reduce the pressure going through the knee joint. We then may go up the ladder with simple analgesics. So if you're taking simple paracetamols or non-steroidal anti-inflammatory drugs. Now, these aren't always appealing to patients, and understandably, they wish to avoid taking medication and want to look at sort of more natural remedies in managing knee arthritis. So then we go on to injections within the knee joint. Now, the injections range from having simple hyaluronic acid injections, which we discussed in my talk about it being acting as a shock absorber. Now, this is a good place to start. Lots of patients come to see me about PRP within the knee joint. Now, PRP stands for platelet-rich plasma. This is a preparation where you take a sample of your blood, you spin the blood cells, and you take the platelet-rich plasma from that, which is separated from the other cells within the blood, and this is injected into the knee joint. Now, PRP has had excellent evidence in managing different inflammatory conditions all around the body, including tennis elbow, arthritic areas, patellar tendonitis. The current guidance on NICE is that the evidence is still being collected as to the degree of efficacy, how long it lasts for, how well it actually does. But in my hands, this is something we have tried, and it works well in my hands in early arthritic patients. It's not the panacea of treatment for early osteoarthritis, but it certainly seems to have had some beneficial benefits in doing so. Now, if you're a bit further down the line, and we've had an MRI scan and arthritis demonstrating you've got arthritis in one part of the knee joint, and you have you're either slightly bow-legged or knock-kneed, then we can start looking at surgical procedures, which would be to make that limb straight, take the pressure off that joint to stop that arthritis progressing. And that is something that has been incredibly effective in the treatment for my patients who've got osteoarthritis, and certainly is being recognized internationally as a joint preservation method. So if your surgeon talks to you about osteotomy, that is what they are referring to. Okay. So and then we start going on to joint replacements and things and such, and that's really the end stage of treatment. I must add, I do also use braces in the early management of osteoarthritis.
Right. Thank you, Rags. And we've got a good collection of questions that are coming through, some of which have been answered. For example, how about PRP injections, and what about things like stem cell therapy, which I think you touched on. Ozone injections, have you come across that? Prolo ozone therapy, ozone injections into the capsule of the knee. That's from Paul.
So thanks, Paul. Paul, this is something that I've read about and don't have any first-hand experience of. Like many of these therapies, I suspect as time goes on, and I'd like to think we're at the forefront of trying the latest treatments with a good evidence base. And I look forward to getting some more evidence for the use of prolo ozone therapy, but certainly at present, the data isn't quite there yet for us to try and use that in early arthritis. But I think it's an exciting space, something we shouldn't ignore, and something we look forward to getting more results for.
Let me, so I think perhaps we can move on to the second half of the presentation, which will answer a lot of these questions, but let me just read a post here from Sarah, who I think sums up a lot of the frustration and difficulties that people face in this kind of area. So Sarah says, I've been suffering from a knee injury for the last 2 years and 8 months, and I've been a runner for my entire life, and the quality of life has been severely compromised. I've done everything in terms of conservative methods such as Synvisc and PRP and U-flexor, blood flow reduction, physical training, laser therapy, orthotics, you name it. I'm so sad I'm not overweight and still try walking and biking, and it's irritated frequently with no type of pattern that's identifiable help. And we do see that. So I think the next part of the presentation will go through some of the options that lie ahead on this pathway before we get to arthroplasty. And also just one final point, just because we have Debbie, who's a physiotherapist, who makes a very valid point. As a physiotherapist, I'd say that each patient should be assessed individually by the physio regarding proper exercises and how to progress them. And I think that's
I couldn't agree more.
People need to get proper clinical care.
Yeah. I'm sorry to hear, Sarah, about your current journey. And, you know, I think this is something, you sound like a very motivated type of patient. And certainly, it sounds like you just need to get in front of the right person to be able to help you with your arthritis.
Yeah, so let's go through.
I'm just jumping in very quickly, Richard, sorry.
Sure.
I think that there's a lot of interest, and it would be a pity to rush to the next section, the knee injuries session. We can always come back. Can you just go through a few more of the questions?
Yeah, absolutely.
Well, I'll leave it up to the audience. If they've had enough of arthritis and they want to go on to knee injury, just say so.
Let's carry on. So just a follow-up question to the running. Any difference between a treadmill and an elliptical trainer? Is one better than the other for the knee?
So I think in terms of the difference, no. I mean, the most important thing is the right footwear that you use, because the impact that you take, if you've got good cushioned shoes that have been tailor-made for you, so you've had somebody look at the foot shape, your overall alignment, the way you impact on the ground. This can be done. This doesn't need to be done in a specialist setting. Most of the athletic shops will have a simple mat that you can perform a small squat on, and they look at your footprint afterwards and see what the rotation of your foot is when you're putting pressure through it. So my recommendation is to have good footwear, and between the two, as far as I'm aware, I don't think there's any major difference.
Okay. You're going to touch on in the next part one of the procedures that I know is very close to your heart, which is that of osteotomy, changing the alignment of the knee. If you've got your knee's not straight, there's my camera, your knee's not straight, all the weight's going to be going on one side, and that side's going to wear out, so you can realign the joint. We've got a patient, Neil, who's undergone an osteotomy, so I'll read out his question. I'm fit, in my mid-60s, who had a high tibial osteotomy 8 months ago. Strong in some areas, but doing hamstring curls are a real problem and seems to catch on the metal plate. The physio thinks plate may be ready to be removed, but problem seeing my consultant at the moment because of the issues, I presume. Any advice on that? What's the
so I'll just go through osteotomy really briefly, because I think it's a really important topic, and one that everybody knows about, doing good physiotherapy, injection therapy, tablets, but very few people know about osteotomy. So just to briefly talk about it. So as Richard touched upon, if you have bow legs, that is to say that your knees are apart when your feet come together. When you drop a line from your hip down to your ankle joint, the pressure going from your body goes through the inner aspect of the knee joint. So typically people who have bow legs will have pain on the inside of the knee. Now, the pain is then as a result of osteoarthritis. The operation that we do is to make the legs straight so that the two knees are now close together, and the pressure going from the hip down to your ankle then goes to the middle part of the knee, or just slightly on the outside of the knee, so that you take the pressure off the inside. Now, this procedure typically used to mean a few days in hospital. It used to be quite a sore procedure. used to involve big incisions. So the techniques have evolved. I've been thankfully trained by the guys who have developed the techniques, Professor Wilson being one of them. We've pioneered the techniques in making it much simpler. Patients can go home the day after surgery. In some places, they're going home the same day of surgery. They take the pressure off the inside of the knee, and within a few weeks, they start to notice the difference of losing that pain that they had, that niggling pain on the inside of the knee. Now, conversely, people who are knock-kneed, that is to say that they can't put their feet together because their knees come together first, they can also be straightened, but they typically have pain on the outside of the knee, because if you draw a line from your hip down to your ankle, the pressure goes through the outer aspect of the knee joint. And similarly, you can do an osteotomy to take the pressure off the outside and make it go through the middle of the knee joint. This extremely powerful procedure, which doesn't burn any bridges in terms of any future operations that you may or may not require. And if anything, in our series of patients where we've done lots of these, patients haven't required, so something like less than 15% of patients have gone on to have replacement surgery at 10 years. So it's extremely effective.
And then
regarding the question, so I'll answer the question. Yeah. Routinely, when I do an osteotomy operation, I do this. There's one question asking, is it just done privately or on the NHS? It's done in both sectors, but it's available to everybody. In my practice, I routinely remove the metal plate a year to 18 months after the operation, providing the bone has healed in the area where we've done the osteotomy, because as Neil says in his question, it can cause catching of the hamstrings. He's clearly got an astute physiotherapist, because that's right, it can cause some discomfort.
Okay, but if Neil's not unable to see his surgeon at the moment, is there cause for concern over that, or is it just a case of discomfort? Is it going to do any harm?
It's just a case of discomfort. It doesn't typically cause any problems, and for many years, people have lived with their osteotomy plates. This is just my routine practice, because if I see a significant improvement from the osteotomy, removing the plate typically adds a few more percentage points onto that degree of improvement.
Okay. And the other question about private versus NHS from Lisa, she asked about osteotomy, but also PRP. Is that something that people can get in public healthcare?
Sadly, no. In terms of public healthcare, it's not currently available. I think that's largely due to more research trials that are going on to prove its efficacy. And we hope that once that evidence is available, NICE will approve it, but currently it's not available.
Okay, and privately, I know that it's difficult to put a number on it, but what would be the cost of a course of treatment for early OA with PRP if you were to self-pay for it?
That's good. I think they're typically in the region of £200 to £300, I think, for an injection, is my understanding. It may be more than that. Please don't hold me to that, but it is in that sort of region. And
do you have one injection, or you'd have a few for that?
So for osteoarthritis, it's recommended that you can have one injection, and it's an amplified effect. So if this is your baseline, and you have PRP, we expect this degree of improvement. And then if people typically recommended to have 2 or 3, they should get incremental improvement. But if you just go for the one, you should get some improvement. And of course, there are lots of different preparations of PRP with varying degrees of what the PRP is made up of. But you can have one injection or a course of 3.
Okay. Just going through, we've got a lot of questions here. So there's a question from Joe regarding her treatment, which Sheila suggested that we answer once the next presentation has gone through.
Okay.
Question from Sarah, who asked the previous question. Again, we'll come to that at the end. Angela's had good results with sorbethane insoles.
Yeah.
So podiatry, I guess that is your choice of well, and could you talk about bracing as well, because there's a question earlier. So if you have surgery to correct the alignment, that's a permanent solution, hopefully. But you can have a brace that can do the same kind of role. And also, what can you do with footwear to try and help you?
Yeah, so as I was alluding to earlier, with regards to footwear, it's vitally important that is looked at. And you know, as surgeons in the past, we've always focused on the joint that we're interested in, and we don't really think around the knee joint itself. So for me, I work very closely with my orthotics team to make sure that the footwear is suitable, and if patients require insoles or require different types of trainers, that you go and see someone who's an expert in that area, and typically that would be an orthotist. Now, regarding the braces, braces are essentially, in my practice, would simulate what an osteotomy would do. So if you've got arthritis affecting the inside of the knee, and your knee is bowed, and you've got one part of the knee bone in contact with the other, the brace, what it would do is just try and separate the two ends together and stop the arthritic parts coming into contact with each other, which is why you get pain. So braces can be incredibly effective for those patients who wish to avoid having surgery, which is entirely understandable. For example, some of my patients who are policemen who spend a lot of time on the road walking, who've got pain either on the inside or the outside of the knee, and I've prescribed them a brace, they love it. They're able to do their job, they're able to get out and about, walk long distances, and some of them have then come on to say to have osteotomy surgery because they've recognized the benefits of wearing a brace. And an osteotomy essentially is a more permanent version of wearing a brace. So the message is wear good trainers, make sure that you have the right insoles or foot orthotics for good walking, and braces are incredibly effective. The patients don't always like them because they can intrude with your trousers, but the modern braces are so slimline that actually you can typically get them under a pair of loose trousers, not under your skinny jeans necessarily, but they're very effective.
Okay. So let's move on. We won't ignore any questions so long as people are happy for us to get through them. Let's move on to the second part of the presentation. One thing I will say, Malini's put in a point that some of these procedures aren't available, and he would like to have a doctor answer the question now, and that's difficult with the restrictions that we've got. Just to say that most, well, a lot of clinicians, at least privately, are now carrying out virtual consultations, as Mr. Khakha was saying about physiotherapists. And in fact, on the Knee Guru website, you can sign up a consultation within a few days to have a chat with somebody if it eases your concerns. So do explore during this time the ability to do a Skype or a Zoom consultation. They're readily available, and you can talk to the leading people in the world in a way that wasn't possible just a few weeks ago. So Rags, let's move on to the next half, and as I say, we'll collect the questions and we'll come to any that are left over. I'll switch off now.
Great, thanks Richard, and thanks for the question. So we're just now going to move on to knee injury. So like a lot of things in medicine, not a lot has actually changed. We know that if you do sustain a knee injury and you start to get knee swelling, the very simple things are that still remain the most effective. So using swelling management, using the RICE principle to rest the knee, the use of ice to help the swelling come down, combine that with compression and keeping the leg elevated. Now, people often ask me, what is elevation? How much do I need to keep my leg elevated? Well, a simple marker would be that whatever you are trying to elevate needs to be above the level of the heart. So with the knee joint, that often means lying down with some pillows underneath your feet to try and drain the fluid back into the normal blood system. And now you may have come across professional athletes who typically have injured their knees on the sports field, or injured any limb for that matter on the sports field, using cryocompression devices. There's one of the devices that we use. We typically use these with injuries, but also post-surgery. And they have revolutionized the way that we manage our patients in terms of the reduction in the amount of painkillers that are required after surgery. They've stopped the significant degrees of swelling that kicks in after an operative or injury procedure. And they work by applying compression and ice at the same time. So cryo being ice, compression being the compression element of it. And this has changed the way that we certainly look after our patients having had an injury or undergoing surgery. Now, the Joint Royal College of Surgeons across the UK, that is to say England, Glasgow, Edinburgh, together with the Irish Royal College of Surgeons, have issued guidance during this particular period of time when we need to urgently medically manage patients. Now, during this COVID-19 period, it is important to manage an open fracture urgently. That is always the case. That is to say, when anyone sustained a break in their bone, the overlying skin is also torn and it communicates with the fracture. That's an emergency. Painful, hot, swollen joints. That is when you have an infected joint. Joints that have become dislocated. We're very aware of patients who have had shoulder dislocations, but this applies to any dislocated joints, and a syndrome called compartment syndrome, where someone's broken a bone or injured a bone, and the swelling within that limb is such that it requires urgent surgical intervention. So just going to touch upon more each of these in turn. A septic joint is an infected joint, septic meaning infection. This can affect joints that are both replaced or somebody's own joint. The typical presentation is someone who's got hot, painful swelling around a joint and may feel unwell in themselves. The management of this is urgent treatment to take the fluid off the joint, and may require surgical intervention to wash the joint out, as well as supplementing the treatment with antibiotics. Now, injuries that may require intervention within a month may involve patellar tendon injuries or fractures around the knee joint. A locked joint is one where you may have twisted the knee and you're unable to fully straighten or bend the knee joint, or injury of a part of a knee where you've injured the cartilage, and that bit of cartilage may require removal, replacement, or fixation, as well as injuries involving the nerves. So as we touched upon, the extensor mechanism, that is to say the patellar tendon, quadriceps tendon, or the patella itself, these typically require surgery to get them working again. Now, this is the one I wanted to focus on mostly, a locked knee, which is typically due to a tear of the cartilage. Cartilage and meniscus are used interchangeably. Now, most patients will have sustained this when they've twisted their knee joint, and they may have pain and swelling within the knee, and they typically are unable to completely straighten the knee joint. The reason this occurs is because they've got a bit of cartilage stuck in the knee joint, and it doesn't allow you to fully straighten the joint. So how do we manage that scenario? We manage that by examining our patients, performing an MRI scan, and in our practice, this is considered to be urgent, certainly to relieve the locking within a 72-hour period. And we relieve the locking by either repairing the torn bit of meniscus or cartilage, or taking that bit of torn meniscus out if it isn't repairable. Another presentation of a locked knee may be due to a displaced piece of cartilage, typically associated with somebody who may have a patellar dislocation or an underlying condition called osteochondritis. Now, the knee may lock or give way, and it may present as being painful or swollen. The management is very similar. It's important to clinically examine the patient, typically supplement that with an MRI scan, and in this instance, surgery may be delayed up to 3 months. Now, if you do have a displaced fragment, piece of cartilage, we may manage this by doing keyhole operation to identify the displaced fragment. If it's not repairable, we can remove it. And then it's important to have other options available to replace that bit of cartilage that's been taken out. That may be using tissue scaffolds, known as AMIC, or using donated bone plugs from patients who have donated their bodies for further use for the betterment of other patients who've had injury. So donated bits of cartilage or bone, known as osteochondral allografts, which have now recently come into the fore as very modern surgical techniques in managing patients who have got bits of cartilage that are missing, but the rest of the knee joint is in good condition and they don't have arthritis. If that piece is repairable, we can repair that fragment using either small screws or small absorbable darts. So in summary, to coming up towards the end of my talk, as we've discussed and heard from people who are listening in on this, osteoarthritis is a chronic and debilitating problem. Injuries still remain prevalent and may need attention. It's important not to suffer in silence, and as Richard alluded to, there is still help available should you wish to, should you require it, and there are lots of options available. Now, Richard has kindly, and his company have kindly offered anybody who is seeing their consultants who are due to have knee replacement surgery on the National Health Service, and sadly have not been able to have their operation because of the current situation, you can have these treatments free. They require approval with your doctor and liaison with your current, whoever your doctor may be, to have the hyaluronic acid preparation, which in this case is called Monovisc, or a combined steroid and hyaluronic acid preparation, which is called Cingal. Each patient will then be requested to be enrolled on a follow-up program with one of their researchers. And if you would like more information, I'm sure Richard and Sheila will be able to provide this for you. It's available on the Joint Operations website. I'd like to thank you for your time that you've taken to listen to me today. I hope it's been useful for you in learning about osteoarthritis, the different techniques that are available in managing such conditions, and as well as giving you guidance as to what the current guidelines are should you sustain a knee injury. These are my details, and many thanks once again to Sheila and Richard for having me on Knee Guru. Thank you.
Thank you very much, Rags, and that's a really informative talk and very up to date in terms of where we are at the moment. Just moving back to the questions that we have, there's obviously different levels of arthritis that people are suffering from. So we have a question from Joy Pattinson, asking about bone spurs. What can be done about bone that's continuing to grow? And she has no cartilage in her knee, bone spurs, but doesn't want to have an operation. What would you suggest is the best course of action for Joy?
So just to explain a bit about bone spurs, the analogy I tend to use is that the bone spurs are there to they typically increase the surface area within a joint. So the way to think about it is if you're standing on soft ground and you're wearing heels, your heels will dig into the ground because the surface area is small. Whereas if you're wearing boots, your heels won't go into the ground because you've got a greater surface area. So by having a greater surface area, you reduce the pressure. So it's just the body's way of reducing pressure within a joint. Now, spurs per se are as a result of arthritis and are not typically managed with spurs alone. There's no way of getting rid of the spurs. There's certainly, you can take the pressure off the spurs with using braces as a sort of non-operative technique. But there are no sort of non-operative measures that I'm aware of removing such spurs. And they can be painful. They cause pressure on the ligaments around the joint, particularly on the inside of the knee. People will complain of the inner ligament being irritated by these bone spurs. The only way to truly manage those is either surgically removing those spurs as part of your replacement procedure, which is what I do a lot of, or taking the pressure off them through osteotomy.
Okay. A question from Thomas. How do you differentiate between anterior knee pain, so pain at the front of the knee, and the pain of medial or lateral, so the middle or the outside of the knee, arthritis, as they can coexist? And I guess this is from a patient's perspective, or maybe you could answer both from a surgeon's perspective. How can you judge that, and also from a patient, what can they do to understand how prevalent the issue is, the arthritis is?
So yeah, really good question. So it's all based on patient history, clinical examination. So to differentiate between anterior, medial, and lateral knee pain, it's from a patient perspective, it's a slam dunk for me when a patient comes in and they point directly to one part of the knee joint. So I split the knee joint into three, and typically I ask the patient, if you could put your hand on any part of the knee joint where it hurts the most, let me know. And they will typically say either it hurts the whole of the knee joint, in which case they grasp the whole of the knee, and that, as a surgeon, indicates that the arthritis is likely to affect most of the knee joint. So that's without me even laying a hand on the patient, that we get so much from the history and the patient's telling us what the diagnosis is. If they then put it on the inside of the knee, it's typically isolated to the medial compartment. Front of the knee is typically associated to the joint between the kneecap and thigh bone. And then the outer part is the lateral compartment, so the outside of the knee. Now, we supplement that with pressing on that part of the knee joint. We're not doing that to be unkind, but it's to isolate exactly where the arthritis is arising from, because that directly then tells us what the treatment needs to be. And then we supplement all of our clinical findings and history with a very simple X-ray, which I use to confirm what I think is going on, but and not to give me the diagnosis, but actually confirm what I think is actually happening. And they can, to answer your final bit, is they can coexist, and that is typically when patients say the whole of my knee joint hurts.
Okay.
I hope that answers your question, Thomas.
There's a question here from Angela, and I know it's very difficult to speak about specific patients when you don't have all the information to hand, so maybe more in general terms. So Angela is a patient who dislocated her kneecap and ruptured her NPFL 5 months ago. Maybe you could describe what the NPFL is. Unfortunately, she still can't walk properly or kneel, and what's her prognosis? So on the basis that Angela's had conservative care, she's not had a procedure,
Yes.
What would be your advice to her?
So just to explain Angela's current situation, the NPFL stands for the medial, so that is to say on the inside of the knee, patellofemoral, so the patella and the femur ligament. So when you dislocate your kneecap, so if your kneecap is sat like this on top of your femur and it comes off the side that it's come off, you rupture the ligament. Now, if that's happened as a one-off and it doesn't happen again on a repeated basis, or you don't feel that your kneecap's going to dislocate, typically we just manage this with strengthening the quadriceps and getting the knee range of movement going, and it doesn't always require an operation. Now, if you're in Angela's situation whereby she's finding it difficult to walk properly or kneel, my concerns would be that there would have been some cartilage damage caused at that time. So the way we diagnose that, obviously having taken an appropriate history and examining, would be to get an MRI scan and see the exact extent of the damage caused to the undersurface of the kneecap or the top of the thigh bone. And depending on the degree of cartilage damage, we can then advise what the prognosis is. Now, if there's no cartilage damage, and it's just simply that it's difficult to walk because you're worried that the knee is going to dislocate, kneecap is going to dislocate, then it may be that you require something to reconstruct that ligament. And the prognosis for that is very good. If, however, there's cartilage damage already established, if it's early on, then the prognosis is good, and it's early on in the disease, we can certainly do something about that. But if it's late on in the disease of osteoarthritis, then there are still things that we can do, but obviously the prognosis then becomes less favorable, but we just need to establish the degree of the damage to the cartilage before we can give you a very specific answer what the prognosis is.
Okay. I think we got through most of the questions. I'll say that we can answer. We've got people's email addresses, so any that are left we can answer through email. Just one final follow-up question from Neil, the chap who's had the catching osteotomy with the plate. If you got a plate in after an osteotomy, can you run on that? What kind of activity would you recommend to someone? And I think Neil was 9 months after his procedure.
Yeah, so Neil, I mean, I'd urge you to have a look at the website as well, just to get some patient stories to see what actually happens. Because, you know, the reason why I smile about it is because most of our patients get back into really good level of sports. You know, we have people who play squash who have gone back into doing triathlons. We have hill climbers, mountain runners. You know, it's for us, it's a real joy seeing them get back into the level of sports that they get back into. So yes, so please get back into running. There's no contraindication in doing that. You can do most sports.
Okay, thank you very much, Mr. Khakha. And so just to finish up, a lot of people are commenting that they'd like to see somebody with your kind of focus that are trying to solve the problem without going to an arthroplasty. It is difficult to see people at the moment. There are opportunities to do these virtual clinics, and on Knee Guru, I think there's a banner at the top with a list of very good surgeons throughout the UK, America, predominantly at the moment, but they can help refer you onwards, or at least give you constructive answers to your questions and see your scans. So there are opportunities for you to get really good advice. For patients in the United Kingdom, we talked about an offer that the company I work with, Joint Operations, has made, which is to provide patients who are in pain that are waiting for probably a fairly advanced procedure to receive the hyaluronic acid injection, and that's at no charge to the National Health Service, or indeed privately. So if you would like to have access to that, you need to get clinical advice from your treating surgeon or physiotherapist, and just give them the link that's on the page, and they'll be able to do that. So this session's been recorded. Sheila will email it through to everybody that's, or link to everybody that's participated. And once again, thank you very much for the audience, for your time, and thank you very much, Mr. Khakha, for a really interesting and informative presentation and Q&A. Thank you.
Thank you very much. Thank you. Thanks, Richard. Thank you, Sheila.